My job at the moment is to summarize where today came from. COIN has always been a network of friends who are interested in developing collaboration and complexity, and with a light touch and humor. In January, we started off with Michelle and Caprice from Canada, who looked at a client-centered model of care that reminded us how desperately, incredibly important it is to have a multidisciplinary collaboration to develop healthy communities. And then that led to John Spicer, back here speaking again today, in February and then March, with Rupal Shah and Sanjeev Ahluwalia, talking about creating meaning through relationships and the desperate importance and urgency of getting primary care general practice to rediscover a sort of a relationship with patients that was built on trust and equality and seeing the bigger picture and caring about communities and families as well as medical aspects. What are the platforms for general practice and primary care to lead collaborative practice, generalism, integrated working? And 1 in 10 people in England are carers at any one time. 3 out of 5 will be carers at some point in their life, and their contribution to the cost of care is equivalent to the entire cost of the NHS and social care combined. That's how much these invisible people who are not supported, land in the role without any kind of preparation, contribute to the national economy. And with the rapidly increasing elderly nature of the population, means that this is only going to sort of be a bigger and bigger importance. So we rehearsed in May, I think it was, the possibility of general practice supporting the development of support for carers around the homes of people who are dying at home, to help them do the work more effectively, developing communities support around their homes, which could be even more cost effective and provide better dying for people. So that was one of the platforms we've rehearsed this year. And then we worked with Steve there and Steve Iliff on the health matters about how we can be clearer that we will write blogs from these meetings and make videos out of these meetings so that there's a trail of these fantastic conversations that we have to leave behind and then help us link with, because we're very well connected, with politics and leaders of various kinds in order to input these ideas into mainstream. And that led to September and October to the great meetings with Sue Morrison and Naomi Kraft, who were looking at the role of coaching and webinars and helping people to develop help people to help themselves. And then Margaret Hanna and Hazel Stutley talking about how communities can develop themselves. And that ended up with stacks of principles about how to make this work. The 2 other platforms we're going to discuss today are primary care networks, and that's sort of James's territory, and then RCGB faculties and city health conferences, and that's John's area.
In 2015, I was one of a small number of people who designed the principles of what has become the microsystem of the new architecture of the NHS in England, that is. And we've now gone into yet again a restructuring. We have a macro system of commissioning on 42 geographic footprints called integrated care systems. They are holding the budget largely for the NHS in their geography. We have the micro system in the community called a primary care network. And that was, the construct isn't quite what it was meant to be compared to where the original principles of bringing together community services, particularly in UK or in England, the 4 primary care contractor services more closely, even though they're separate contractors with separate contracts. Could we bring together general practice, pharmacy, optometry, and oral health dental services into a networked position that might mature into one organisation as well as other community services, and then recognising the changing need, how wider local authority and council services, social care particularly, might become part of a team-based approach on this micro system, which was based around populations of 30 to 50,000. I've got a paper that described why it was 30 to 50,000, which I've never published. And I've heard some great magical thinking since that time of where that came from. One of my colleagues, Navchana, of course, John knows, we're about the only two who really know why we settled on that particular size back in 2015. But the evidence today may be that it's not the right size. Then we've got this meso size called the place-based care, which is a bit jelly-like, grabbing. If you talk to 100 people, what is a place in terms of the meso system, you'll get 101 different answers. It's largely in a geographic fit with local authorities, which manage part of health in as much that public health is cited in local authorities, or part of public health. Fast forward was that I was quite keen to see if we'd have matured the principles from 2015, 5 years on, these primary care networks, these community-based multi-professional teams in a unit that might even have some organisational form, would be starting to address the most complex care issues in our communities, rather than the contractually driven approach that the NHS largely have, and very transactional in silos. It was almost, what would it do in the most complex areas of care, and particularly in health inequalities, or at least health inequity, where people experience very different service from our NHS. So I created something called the Complete Care Community Programme. It's a working title, but it was a programme to start to build field work which could analyse certain things. I'll just show, see if we can share my screen now. So hopefully, that is projecting, is it? Laura, is that okay? Yeah, good. So it's a working title. What we wanted to do was establish the evidence about two things: this new architecture of the NHS, what could its new form have in terms of impact on reducing health inequalities, and could we network this field work that meant that, independent of geography, we could start to learn things that could be translated across England, a tiny country, and establish the evidence behind two exam questions. Because whether we like it or not, we started with why we continued to fail at reducing the health inequalities gap in England. It's a bit of a pointed remark when there's been great people doing great things for many, many years. But if we accept the indicators or some of the metrics we use for health inequalities, not least life expectancy, we're seeing in England for the first time in 150 years that life expectancy is now stalled. The social gradient is getting steeper. We're defining all sorts of new poverty. We now have, as well as rural poverty and coastal poverty, we have fuel poverty, and we're finding more children living in poverty. So despite our best efforts, something is happening that is meaning that there are more people in community who are being marginalised, disconnected from healthcare systems, and outcomes related to health are getting worse in England. So do we know why? Because of great approaches. And what can this new system do? Because the analysis, what everyone says about the National Health Service or health impact on health inequalities, is it's relatively small. And we still accept that. And then we talk about the social determinants or the wider determinants of health. And there's some very old research that says health probably can impact around 20%. It's a bit 20%. We think it's a lot more. It's almost an excuse to say, well, it's all about, and of course it is about whether you've got shelter, have you got enough money to put food on the table, have you got good education. But I think now when I reflect on my clinical time, that we've renamed the wider determinants of health into the core determinants of health. Because my time in health, for example, if you've got type 2 diabetes, 100 years ago, 150 years ago, it was a death sentence. Now, if you look after yourself, the NHS has treatments that can, give you a long, healthy life. Unless you haven't got a home, a job, and a friend, or a social network, So the same disease now, you'll live a long life, but if you're living without shelter, without income, without resources, then it is still pretty serious. So should we be talking about the core determinants and how the NHS works with it? So they're the two questions we're trying to answer through field work that we've developed in 65 demonstrator sites, and each demonstrator site is anchored in a primary care network. But quite quickly, when the network is challenged to produce, and we're talking about a single project, a project that clearly identifies a cohort of people, horrible term, but a segment of population that have characteristics that brings them together in ways that defines some of their debility through health inequalities. But what happens then is the primary care network, which is largely an aggregate of health bodies, particularly general practice, has to start building new conversations, new relationships with community services by the very nature of the conditions they're looking at. So we've got projects that are looking at homelessness on the south coast, travellers communities in Cornwall, sex workers in Nottingham, rural deprivation in Cumbria, and everything in between. So we're saying it doesn't really matter where you are or what project you're doing. We want to learn from the experience of developing a service based on this new microsystem of the NHS, but recognising that you're going to have to build very different approaches to delivering the care for a clearly defined population. So we've got in all 7 regions of NHS England, we have 65 sites. The aggregate population coverage of those 65 sites is about 3 million people. So we think we've got enough to do some evaluation, and we've set a framework. As you'd expect, we're using the quadruple aim as the framework in which we're starting to evaluate what makes people tick in each of these small groups of people who are developing the projects. What makes them tick? What is it about them that is at a time of great pressure, a very cold financial climate in the NHS, driving them to do this complex care work? What is the experience then as they're developing projects of people who were disconnected from the system, marginalised, hard to reach? And I make no apology about that terminology. We spend far too long on semantics to try and rename, is it people without voices or inclusion? It's a case of there's some people who are not getting service that they need and deserve. What was their experience? And we're finding all sorts of things, revealing answers that I'm thinking, why did it take me 40 years to get there? Because some of what sounds like simple answers, when you actually listen to these groups and then start to design, you come up with very different models of care than what the NHS normally designs. And we want to make sure that we don't have the not made here syndrome, sometimes called by the NHS, because I remember at an early stage, I was a GP in Merseyside, a place called Wallasey on the Wirral Peninsula. I probably went around about it the wrong way when celebrating some of our successes in a single practice, maybe getting an award. It was the wrong approach. But my first experience was colleagues in Birkenhead said, it's all very well, James, in Wallasey, but that will never, ever work in Birkenhead. Very, very different population, 2 miles down the road. And we have that all the time. So what we want to make sure is that all this geographic coverage, we're finding things that aren't dependent on geography. I won't go on too long. And Paul, you call time when you've the design of the program. I've got a small team of 10 people who are helping with the design principles, and it's interesting at how many the enthusiasts, particularly in the health service, want to jump straight to a delivery model rather than saying, well, let's just really have a look at the design. Do you know the extent of the debility? Do you know each and every one in that population group that you're going to look after? Because many people who are marginalised, they're hiding from us. They're not easily found. And what we generally do is start to build a service and hope if we build it and open the doors, they will come. It's a bit like the field of dreams, build it and they will come, as opposed to saying, well, no matter how hard you try. We found a lot of sites saying we built a great new service, but no one turned up, but it was in the wrong place. It wasn't designed based on the wishes of the population group. And it's interesting when you start to listen, you make differences of design. We're using simple principles of population health analytics and then managing it through a very different team design. And the other bit of the 4Ds that we've discussed is the dissemination. The hypothesis is that we, for want of a better term, fail at sustaining great projects, particularly looking at complex care, health and inequalities, because we don't understand how to transfer. I use an unfair example, a great example in not too far from me, Wigan. Some of you may have heard of a compact that was developed by the council for healthier lives for Wigan residents, and it was called the Wigan Deal. And it got plaudits, it got awards, and rightly so. It was a really interesting approach for residents of Wigan to lead healthier lives through a new compact between health and social care and local council. But it was the Wigan Deal. We never got a Bury deal, a Bolton deal, a Blackburn deal, a Preston deal, or any other deal. Lots of people visited. Lots of people said how great it was, and lots of people took bits and pieces back. But it wasn't something that was properly disseminated. And it's another part of the hypothesis. We always talk about being innovative, but what we tend to default to is invention, and everyone wants to invent their own. What we don't do is, what do we learn about the principles of that invention that leads to the most important bit about innovation is the adoption, the spread, and how do we scale? What is the science of scaling? So we're looking at design and dissemination, the development of the project and the delivery. We want these projects to become business as usual in this new construct of the NHS, and integrated care systems and their boards start to commission them in the long term, because we don't have recurring money for these projects. We had a bit of seed funding. I won't go on to that one. Just the longevity of the project. We're into our third year. We're into the third phase, and we don't think we're going to develop any more demonstrator sites. But this is probably going to challenge us more than anything else. That just an aside, on the 8th of November, a letter went out to all of these integrated care systems and their boards saying basically, down tools. The only game in town now for the NHS up to the end of March is urgent and emergency care. What we don't want to see is ambulance queues outside hospitals and being reported at News and 10. And if the Prime Minister's rolling his sleeves up and walking down A&E, he does not want to see people on trolleys. Now, I'm paraphrasing, I'm being a bit disingenuous, but this was probably the greatest blow to enabling projects like ours, or programs like ours, to continue with any NHS funding, which we've enjoyed to date. But we're working on that at the moment. It's the where are we? The fifth bullet point that really got me annoyed, actually, really annoyed. That this letter saying that where your focus and only resources in largely urgent emergency care, you need to. I think the other thing was it's all the doctor's fault, of course, because it was saying this was all as a result of industrial action, which we know it was part of, but not alone. And in a report that was warning about damp homes, effects on babies and young children and people, and having serious health consequences, to say it was the service and its industrial action, and you've got to reduce lots of staffing, yes, agency staffing at this time of year, are great, but what we are going to do is spend millions of pounds on McKinsey's to write the solutions for us. That's the bit. I'll get off my hobby horse now. And but it was just one of those issues that the NHS is continually challenged with, and we will be reporting about resourcing. The allocative value that we're finding in the NHS is a big issue for health inequalities. I think I'll probably finish there. Oh, there's the only quiz question for the night. Because sometimes we are finding that we do try harder at what's already failed, as opposed to taking different approaches. And this was attributed to, who knows whether she actually said it. She lost her head over it, I guess, Marie Antoinette. But it does seem as though we do try, and what we're finding is inventing things that we think is new, but it isn't. What we need to do is have a much better organizational memory, a much better approach at transferring knowledge and adoption, and leave it less to new inventions. I'll stop sharing my screen at that point. because I appreciate I've taken a lot of time over there, and I can get, as Paul knows, probably as others who've heard me say, get a bit garrulous on this topic. But just to finish off, Paul, is whether that sort of approach, using the architecture of the NHS in England, might be something that aligns with some of what COIN has been doing, using primary care networks, looking at the most complex areas of care. But there's the information we're finding through the evaluation to date is actually astonishing. And I say that as a person who's been in the NHS for 40 years. I'm finding issues that, wow, where have I been for 40 years?
James, I want to start off by asking you, 24 of your 65, I see from your slide, are in the northwest of England. And if everyone is just concerned about actions in emergency, but the Labour Party is likely to come in to government in a year's time, and it is much more concerned about these things like community development than the present government, is it possible that the 24 could form a force for discussion about what works?
Yes, I guess. Yeah, the map spread, and there's a little bit of skew, but we wanted to go where the energy is, and the energy both in terms of the clinical teams who are prepared to join this program, but also where ICSs or NHS regions were interested and wanted to put some funds into it. And we had most enthusiasm from the Northwest region, Southwest region, and part of London. So we do see we've got more in those areas. We did lobby in the other regions to make sure that we had some national feel to this, so each region had some sites. But yeah, a focused project where there's most.
I mean, it includes Liverpool and Manchester, and we've got a lot of connections in those two places. Making these things work means that people design things from the inside out, that they collaborate in a more lateral rather than hierarchical way. They think about health as well as disease and sustainability, all the stuff we've been talking about, link into that, into global warming stuff, and get the Northwest to talk about it.
It occurs to me, and I know you're saying Northwest region, but that some of the energy that I came on the wave of in Northwest London is that there are a lot of quality improvement efforts that were happening around some of your work, Paul, and part of what I was involved with at King's in studying how the IHI work was coming into the NHS and how the Plan, Do, Study, Act cycles were being taught. And I'm in the classroom this week with undergraduate nurses here in the US, and we're teaching them those very same ideas. And as they go out into their various units in a very large hospital system, they're recreating the conversation over and over again, as if all of the hospital has never heard of these quality improvement efforts and aren't using the same language. And so the idea that we have to keep recreating the conversation, the glossary, the terms, I guess I'm trying to come to two conclusions. That one is that the energy sustains over a long time. And so you may be getting more concentration of effort in places where that effort has been continual. And two, the same question I kind of always raise on these calls is, are we measuring the right thing? That I do think that there are wins. There are places that we are making an improvement. And you're right, the general numbers around inequity and inequality seem to be going in the wrong direction. However, have we gotten the measures right? Are we looking at the right things? Because there are people everywhere making efforts in the right direction. Just having 65 demonstration sites is a huge move in the right direction.
Are there any particular common themes from, I know you're talking about different populations with different sets of circumstances, but are there certain common themes that have emerged that could be applied, very clearly across the piece?
Yeah, some of the issues for the NHS, many are finding we've got to completely rethink registration. Registration is, you can get free at the point of need, not based on your ability to pay. As long as you're registered, for NHS services, and that's with a general practice. And many of the communities who are not being well reached, hard to reach, are not registered. And there's lots of areas. Central Liverpool is a good example of rethinking how you reach out and connect people with the NHS, which may not be through registration with a general practice. Now, that is a fundamental building block of the NHS, but it's not just being found. There's many sites saying that just doesn't work for these people. So if we're saying the way you're going to get treatment is register and turn up at the general practice, that is a major barrier for many of these patient groups. We've coined a new phrase, and I've checked it. There's something called language concordance, but we've decided on a term called language empathy, particularly for those people who don't have English as their first language. But we found it in 4 or 5 sites where, of course, you would get interpreters. NHS England have a website with choose your interpreter. But in those sites that we're finding, the interpreters were making things worse for those groups, because they weren't interpreting feelings or their concerns, the ability to just change language. They needed so much more than that. And even some interpreters were interpreting their own way of passing on information. An example was a group from the Middle East, where the interpreter, it was ladies who weren't getting gynecological services. Well, it was interesting. One, there's no term for menopause anyway in certain languages, and which is difficult when you're saying I want some menopause treatment for menopause. But others were, you should not be sharing this sort of information with male doctors, because it was on religious grounds. So the extent of it was that we have this funding. So you know, the additional roles reimbursement scheme, which was a bit clunky. It's becoming a bit more flexible, where you can start to invest in different types of health and care professionals working in your teams. Well, in Derby, they've now appointed a full-time Slovak interpreter. And I'm not saying that's the right way forward, but they've got a huge population of Slovaks in central Derby, most of whom don't have any English. They'd set up all sorts of services for them, but they weren't being used. And the disconnect was this language empathy, just being told in their language where to go, as opposed to understanding their need and transferring some of their expectations, that the fears they've got about a certain service, meant that they said it was well worth an interpreter who understood a lot more about the medical process, rather than in the morning working for the Home Office, in the afternoon, you know, working in a police or the prisons service, and then working in health, and just changing language. So there's a whole range of things on something we're calling language empathy. The final one is place of care as well. Issues for NHS estates, whereby 3 sites now who are looking after people without any shelter at all have got mobile estates. You know, the health bus. But interesting, don't sort of go, aha, we'll get a bus as well, because the first people who did that, they bought a bus, equipped it, they started to drive into town, and then they couldn't park it anywhere. The council would not let them park. There's loads of simple practical issues, but the estates issue is we may need to rethink the estates for people who are disconnected or marginalised, because again, other sites were saying, there was one site looking at a group of high deprivation children living in this area with obesity. And they, of course, went straight to a new service and opened it in a health centre, and no kids turned up. They didn't want to go to the health centre. So quickly they said, oh, we'll move it to the school. And no kids turned up there because they didn't want to be in there. So they said, oh, we'll move it to a community centre. And no kids turned up there. And then they found this new place in the community that they rented, and all the kids turned up. And I remember saying, how did you come up with that? You know what they said? We listened to them. Instead of our best intentions about the right place of care, or even the right care. So getting it, we're saying that there's something called getting it right first time, which is largely a hospital-based system so you're not duplicating service. You know, when you're doing an operation, get it right first time. There's a whole get it right first time in this process when you're dealing with these groups of people who have always been disconnected from the mainstream, from being marginalized. Sit down and listen as the start. It sounds straightforward, but I spent a lot of career acting in the best interests, but sometimes not listening, and then wondering why you produced a service. So sorry, I've got a list of things, but these are the sorts of things. So everything from, you've got to rethink NHS estates, you've got to think about the language, you've got to think about how you register, and the biggest issue is the allocative value. The NHS allocates in ways that link into the metrics that are important to the system. So it's all allocated, as we're seeing. That's what I was saying in winter. It's allocated about length of stay in hospital, readmission, waits for A&E, schedule care, how long you're waiting for your hip replacement. So if you're, I'll finish with this one, but it's emotive. And I started saying it, I thought I felt a bit worried, but it was a case of saying you're an ICB, the commissioning board, you've got £15,000, and we know you can only spend it once. We're in a very cash limited, and you can spend it on a white middle-aged man who needs to get back on the golf course because they need a hip replacement. And as a voter, could be me, I don't need a hip replacement yet. Or you can spend the same £15,000, this was an example in Truro, on 5 troubled families who got kids with complex mental health problems. But you could help them with education, food, and for 6 months we worked out the £15,000. It might even take 2 of those kids out of a life that might cost society £30 million if they've had an adverse childhood experience, and they then, in later life are being managed by the justice system and social care or even prison service. So you might move, and that's only going to cost you £15,000. Where are you going to spend your money? 100% of the time, get the white chap off the orthopaedic waiting list, because that's the metric of success in the NHS. So if that's our allocative, and I'm not saying we shouldn't do that, but if that's the allocative value, and that's the one example, and you can only spend your money once, we'll get to these kids who are going to bed at night with their bellies empty and have got complex mental health problems. We'll get to them later. Let's just make sure we get through winter, not increase the orthopaedic waiting list, and for God's sake, let's not have ambulances queuing outside a hospital, which is really important. But if that's where we're going to focus our efforts, and that's the metrics of success, it's another issue that we're feeding back to the DH.
Is there an international perspective to this? I'm just looking at colleagues from other parts of the world. Have you got common areas of experience or thoughts from the US or from Italy or Greece?
I just wonder if there's something fundamental in how human beings are, that these ideas do need to be reinvented in new locales, that we need a way to make them part of our story. I mean, we have this, I think, this hope that we've discovered something and we just need to disseminate it or scale it. And for a lot of the things we're talking about, where we're asking people to change their worldviews or to develop understanding outside of their personal experience, I wonder if they do need to reinvent it somehow. And if that's how we might think about it best, how to help people reinvent this, how to make them more rapid, how to get them to focus on it if we think that's important. And maybe in doing that, learn maybe it's not the most important thing for them.
Yeah, using human psychology of groups and people and individuals. Yeah, it is an issue in this country, and I know it's been experienced by others, that the not invented here issue that you mentioned, James, can be a big barrier.
If you could have half an hour with the Shadow Secretary of State for Health, what one thing would you press on him?
Get rid of the GP contract in its entirety.
Interestingly, I don't hear that as coming from the work that you've been describing, but maybe I've not been paying attention.
No, it's just that it goes back to the allocative value. We're in the middle of a major rethink of where most people have first contact care in their general practice. The general practice contract now is completely focused on delivering some of the agendas of the system, not necessarily delivering against some of the issues I've been talking about. And what we found is the biggest barrier for and it's primary care networks aren't just about general practice, or shouldn't be, but generally most are working as an aggregate of their constituent general practices. And of course, that's where the population largely is registered with. But then the directives and the micromanagement of the GP contract direct the day-to-day activity of general practitioners and their teams in delivering certain things. So for example, deliver a target for cancer screening, for cervical screening for 80%. And once we've got to 80%, and if we've got 81%, we're done. We're okay. We've reached the target. We've got the income, move on. And the 20% who aren't seen are the ones who are going to get cervical cancer. So it's if you were saying the one issue, I'd say the biggest barrier to address some of the most complex areas of care is we're asking our primary care teams based in general practice to function in a way that probably will never address some of these areas of care. And I'm not saying it's all wrong, but if you said, what's the one thing you do? I say, rethink I think the GP contract has got so complex in its micromanagement and so directive in the day-to-day activity of clinicians. I'm not sure whether it's of any benefit at all now.
No, I was just going to pick up on this thing of reinventing the wheel, and it does come up time and time again. And I'm working on a piece of work about heart failure at the moment that goes across it's for the British Society of Heart Failure, looking at different ways of reducing mortality actually across the next 25 years. And I really think that it's often missed, as I understand why communities want to have their own thing and want to put their own stamp on it, but actually I think there is a case for looking across and picking out what the generic factors are and how you then contextualize them. And I think that gets missed out a lot because we're not pulling out what the generic issues are or what the generic things that are working are. But of course everybody wants to contextualize them because that's what we do. That's what communities do, and that's actually why often things don't actually work, because the community is not being listened to, like you were just saying about listening to the children. And that's what I think is missed. Not that, why are we starting all over again, but because we haven't got that generic core that's pulled out and disseminated.
I guess sometimes I think that if we've got a challenge, to make the challenge bigger is helpful. I love anything that focuses on community and community integration. But I wonder two things. One is the climate crisis, or as you said, Paul, the climate stuff, is getting pretty intense. And I wonder if we think of communities that have to learn to be more resilient in that kind of a circumstance, whether that's going to help us how we organize. And I'm working on an editorial for the medical directors of long-term care facilities in the United States. And I wonder, that's a huge problem where long-term care, at least in some countries, is trying to become more community-based. How, I guess, back to you, are you thinking about in these community programs, those two factors, long-term care and the climate crisis?
Well, interesting, on Thursday in Oxford, I'm meeting some colleagues from the Centre of Sustainable Healthcare to discuss whether the approach we're taking does have some link with the connection between health and the environment. So we're starting to think about it, but we've not really explored it. But that starts on Thursday.
They're all such important interconnected ideas, and it occurs to me that one of the few types of surgeries that are profitable to hospitals are, in fact, these knee replacements, hip replacements, things that can be scheduled. And in many ways, we focus on whether we admit it or not, the system will focus on what's financially beneficial. And so what are we really valuing? And that's my awkward way of making a segue to John Spicer around values maybe and systems.
Sorry. The brief I had was to talk a bit about CPD with particular reference to London. And I'll come to that in a couple of minutes. I won't take very many minutes, and I haven't got any slides. I thought I might just say a few words about the RCGP because it hangs over us. Some of us here are members of it, but I realise that quite a lot of people present don't know much about the Royal College of GPs. in the UK. It's a UK body. It covers all 4 countries. So I think I'll start with that and then move on to what might be a bright idea that COIN may wish to get involved in. So the Royal College of GPs is one of the medical royal colleges. We are 55,000 GPs strong, so it's a big body. It ought to be 6,000 or 7,000 more than that, but our political masters have constrained the numbers of GPs in all sorts of ways. And it claims to be the professional home. I'm not quite sure what that means, but that's what the college claims to be for all GPs. And unfortunately, it is GPs. It often claims to be the voice of primary care, but to be honest, the high-ups in the college would wish the membership to remain exclusively for doctors. Now, I think that might change in the long run, but it's quite a long way away. And that might be one thing we could talk about afterwards. It's influential to the extent that any medical royal college is, which these days is not very much. It likes to think it is. But as we've seen with the industrial action that James mentioned earlier, affecting doctors, nurses, and other professions in the UK in the last year or so, that influence has probably diminished even more. And the college is divided up into faculties, which are geographical. And it goes by population as much as anything. So in London, we have 3 faculties. Paul and I have both been chairs of our respective faculties in the past, and I think other people present may have been, but if they are, I don't know about it. And Lucy knows the anatomy and physiology of the college really very intimately because she used to work for them, organizing all sorts of things, and may be able to share some secrets if she wishes to later about that anatomy and physiology, but no pressure at all, Lucy. And one of the things I do, apart from being chair, or I have been chair of my faculty, which is South London in the past, I'm now chair of the RCGP Committee on Medical Ethics, which Pakita is also on. We're not a medical research ethics committee or institutional review board. We deal with items which our national council wishes to deal with. And give them some thought and some analysis and feedback to council. So there's some hot stuff coming our way in the next year or so. But the reason for that short intro was just to report, if you like, that a couple of years ago, I think it was, we were trying to work it out before this meeting started. We think it's probably 4 or 5 years ago. We used to have a London-wide RCGP conference for all the GPs of London and others who may have an interest, for example, other members of primary care teams. And sometimes research was presented, sometimes we looked at what we were doing in London and tried to think of ways of doing it better. Sometimes we did the bread and butter statutory and mandatory CPD that all primary care team members have to do. And they fell into disuse. You will have noticed that it was around about the time of COVID kicking off. And they've never really got going again, but it is being talked about that should happen again. Now, I'll be interested to know, maybe from colleagues around the country, whether there are any analogues of this. But one of the things we might decide to do is to link into that development of these conferences. I mean, if you think about it, there's a lot of reasons why London should have a conference. We're a big city. We're about 10 or 12 million people. We're an incredibly diverse city, probably the most diverse city in the world in terms of ethnic split or religious makeup or whatever. And therefore, that offers great opportunities for consideration of things like social equity, which James has already mentioned, inclusion, resource allocation, organizational approaches. We're an awful lot of people squashed into a fairly small surface area. we've got a lot of expertise in London, not necessarily more than anywhere else. Sometimes funding streams are alleged to favour London-based health organisations and universities. I think that's probably more an accusation than a truth, but it's something that needs considering. Often programmes within the NHS are accused of being London-centred. So the task maybe is to foster these conferences as they come into being. I can't tell you whether they will be in person or online. I hope they'll be the former. And to work out how COIN might engage with that and pick up some of the trends we've been speaking about tonight, and no doubt many others. But just before I finish, another straw in the wind, apart from the City Health conferences that I've mentioned, is that Wonka next year is going to be in Dublin. Now, you remember it was in London a couple of years ago, and I went down with COVID, so I couldn't participate in it, unfortunately. But the Irish always put on a very good show. And Wonka are interested in the kind of areas that we speak about in our meetings here.
I can't help but put in a small pin for those of us who are in family practice, who aren't GPs, just as my involvement with RCGP through some of your work and Paul's work in years past, that nurse practitioners are forming as a professional group also in England as they are around the world, and are a rising group in the provision of primary care. So there may be some role for understanding the larger multidisciplinary team and how provision of care happens through that, whether it's the NHS or elsewhere.
In fact, we've already got some yeses from various key players in London to say that we could hold one in November next year. So I would like us to see us not just holding a workshop in the City Health Conference in London next year, but actually sort of taking over the agenda a little bit, or influencing it, to have this kind of discussion about complexity and co-creativity there as well. And I'd like us to introduce some ideas like that of Goober and Lincoln's fourth generation evaluation. They eloquently describe previous versions of evaluations that are well out of date, and say that everything is contextual, everything is moving. In order to understand evaluation these days, you need to create complex case studies that are geographically bound, get people to revisit, to come back again. That learning organization idea of going away, coming back, seeing the bigger picture, looking at lots of evaluation markers and coupling that with lots of different views, trying things out and coming back again. We could get primary care networks to routinely gather data, let's say like deaths at home or hospital admissions, or
just that difficulty of getting things disseminated. I mean, for example, I know Helen Kingsland in Compassionate Froome, which is very community orientated and community led project, which led over 3 years to a reduction in hospital readmissions by 30%, and a huge saving in money for the NHS, and everyone a lot happier. And Frances de Cunha, who's a colleague of mine and a long-standing friend, and Steve knows her when she was in Kilburn, but she's working on providing wraparound care when people are discharged, so that again they don't go back, but trying to get more GPs involved and interested has been an uphill struggle, interestingly. Maybe they're too busy, maybe they have all these diktats they got to follow, so they just don't think in that way. I don't know. And Margaret Hannah, you mentioned, with her SHINE project in Scotland, the Nuka project in Alaska, all these wonderful projects that could be adapted for the local population and communities, but somehow they don't seem to be taken up, and yet they don't cost much money, at all. But they do require effort and communication and collaboration. So that's one thing. The other thing, just to mention the deep end GPs that I'm kind of linked up with on WhatsApp, are doing a fantastic things in London particularly, but elsewhere. Barriers to registration, absolutely. I worked for 10 years, as a part-time clinical volunteer for Doctors of the World London Clinic. And a lot of GPs absolutely close their doors to asylum seekers, trafficked people, and so on, because they can't produce the documents. They don't have bills, they don't have passports, their passports may have been taken away, etc. And then just finally, I went on a talk at the RSA by Sir John Bell. He had the solution. His solution was that we all have our genomic, testing. Obesity is the biggest problem. It creates all these other diseases that are linked, diabetes, heart disease, you name it. We all, all these people just given an obesity pill. They have, we check out their genes, what they're, likely to get. We begin to see that there are these counter forces going on. His fix was pharmaceutical, transactional, big rollout.
Essentially, we're talking about helping energy be created to say things that ordinarily aren't allowed to be said, about things like relationships, about co-evolution, about complexity.
I do think there are major forces, as Paquita said. I work in the Alzheimer's space. It's absolutely a nuts space where everybody's going to be on multiple monoclonal antibodies associated with multiple panels of tests. So these forces are really powerful. The reason I raised my hand is there's a movement that's going to be back at Oxford called Preventing Overdiagnosis. It's going to be back there in, I think, 2024. I really think that overdiagnosis, overtreatment is an important lever to try to take on some of these more malignant forces that Paquita was emphasizing.
James has put something in the chat. James, you're suggesting that we should cultivate a future where we develop primary care provision which is not GP centric.
Just a thought, because as John was saying about Wonka, and of course Wonka is about family practitioners.
Yeah.
But it's interesting that if the title of the 24 conference is about the changing future, then it'd be not to throw in a bomb, but within that environment, saying, well, there's a vital role for the primary care physician. I enjoyed being a general practitioner, but I was trained for a particular range of skills, and I had certain competencies, which sometimes I was asked to work outside and become an all-singing, all-thinking, friend, advocate, sometimes priest to the people who are coming in who needed care. So should we be rethinking something that is obvious? It's part of what the program I'm running is that the nature of the ability that certain population groups have cannot be delivered through a GP model. Raise something that is well known, but puts it into context about the multidisciplinary approach to primary care provision.
I think we're at a pivotal moment, James, in the UK.
Yep.
And I think whether or not we as a body should espouse the multidisciplinary future is an open question. I suspect that this group probably would, but it doesn't necessarily have purchase in the corridors of power. But the fact is that we, in day-to-day work, are implementing it. And, I could not work without my nursing, pharmacist, physiotherapy, etc., maybe even priests, as Marini just put in chat. Colleagues, we deliver care that's universalized in that way. Now, we haven't worked out all the nuts and bolts of that yet, unlike some of our secondary care colleagues, and we certainly haven't worked out how our role as doctors fits into the new generalist model, you might call it. I suspect Wonka would be interested in it, and I think it's one of those things where the international perspective is incredibly valuable.
In the US, it's a state by state debate. And certainly from a policy point of view, from nurse practitioners, what we're seeing is that there's a lot of organizational fighting around whether it's a doctor-led team or a multidisciplinary team or a patient-centered team or a patient-centered home. So now you start getting into some of the semantics, but they're real. And the political realm, as we lead into elections, both in the UK and the US in the next year, I think this really is a crucial time, not just for defining the roles, but to putting empathy back into healthcare, to listening to the people who are receiving the care and building from that. And if there are lessons we can take from the demonstration sites in the field-based research that James has been doing, this is the time to empower those conversations in a way that makes it less about fighting for space, but does make it political. And I think
I just want to echo John's point. I think we're at a pivotal moment. I think that people want to do this, don't know how to measure it, don't know how to think about evaluating it, don't know how to train it. Medical schools are stuck not being able to do it, and everyone else is overwhelmed by other things that they can't do. A lot of this is still disallowable conversations, but we know the words, we've got a lot of contacts in these areas, a lot of things are happening, and I think that we in COIN should be using the next 12 months to do everything we possibly can to get this kind of conversation normalized.
First of all, James's discussion and the emphasis on listening to people and how that needs to sort of inform how we develop general practice and what is offered. I think that's really, really vital, and perhaps I don't know what capacity there is to support this type of work, but it would need to be normalized, in my humble opinion. I think with regards to widening traction and sort of building traction for these types of conversations and for them to be also normalized, I think what the suggestions that John made, participating in conferences that are really key, perhaps the power that RCGP has. I remember you, Paul, presenting, when you presented your book at RCGP and how what a great conversation this developed. And so I think it somehow, perhaps the network would somehow have to find a strategy for sort of linking up with powerful organizations or other powerful networks that tend to normalize these types of considerations, and also look for funding and participate in this type of work. With regards to Liverpool that you mentioned, Paul, maybe the Department for Research and Development Northwest, that tends to have a similar emphasis or leads out of the box projects. I've been an associate there for a while, and I could make a link if need be. Maybe that's another possibility to link up. So
awful lot of unsaid things waiting to be said. I think we're going to be doing a lot of behind the scenes work in the next couple of months before the new year hits.
Somebody else has made the point, but this commonality, the sort of common findings, anything that the broader principles that can be drawn from those individual projects, be really interesting to both hear the particular and the more generalizable aspects of those projects at some point.
And beneficial perhaps for them to have a friendly audience. So if you think that any of the projects would benefit from being in a friendly room to bounce ideas around them, then I think the hope would be it'd be mutually beneficial conversation.
Yeah. And I suppose the other thought I'm having really is this issue of learning to listen, and the broader interdisciplinary approach, which has come up several times tonight and on previous occasions. I think we should be looking at how we can foster that through COIN as much as possible in future meetings.